I have gone through 5 or 6 important journals, like including American Journal of Gastroenterology, NEJM, Lancet, Gut, Indian Journal of Gastroenterology. And from these journals, I have selected topics which are of relevance as far as the exams are concerned. But I will be looking more towards the opinions of my seniors and teachers over here, and I'm sure that I will be more wiser at the end of the day. Before starting, let me thank Varghese sir, because as I was telling earlier, ever since my exams, there has not been so many days where I burned more midnight oil than the last few days. So with that, let me move on to the topic. And as James said, I'm already I have a lot of pressure in my head, so I'll think like I will try to do my level best and do justice to the topic that has been given to me. So in the recent advances in gastroenterology, since this is the era of COVID, I thought like I'll just start by describing the importance of COVID-19 in gastrointestinal tract. As postgraduates, I think like there are more and more questions likely from this, at least one question likely from this topic. So discussing with that and then moving on to the other important papers that I saw among the journals over the last few years. COVID-19, as we all know, was noted in December 2019 in Wuhan, China, with an incubation period of 6.4 days and predominant symptoms of fever, cough, dyspnea, myalgia, fatigue, anosmia, and loss of taste. But what is of more interest to our group would be the GI manifestations, which include diarrhea, vomiting, and abdominal pain. Various studies have reported between 10 to 15% of patients with COVID presenting with GI manifestations. And what is more interesting is that 10 to 28%, recent papers show close to 1/3 of the patients have only GI symptoms and no respiratory symptoms. Another interesting fact is that stool PCR is positive in around 53.4% of patients presenting with COVID. And another interesting or alarming fact is that stool PCR may remain positive even after the throat swab becomes negative for a mean of 11 days. And in the recent paper, which is published in the gut, it has been shown that 23.3% of patients remain positive for an average of 11 days, even after the throat swab becomes negative. Why is GIT more involved? It is mainly because of two reasons. One is because of the presence of ACE2, angiotensin converting enzyme 2 receptor, which is a main receptor for virus entry, and TMPRSS2, which is a transmembrane protease serine 2, helps in the fusion of the virus to the cellular membranes and entry into the cell. Both these receptors are present in abundance in the GI tract, in addition to lungs, thereby making it prone for injury and symptoms as far as COVID-19 is concerned. Transmission, as we all know, is because of droplet, aerosol, or contact. There are 5 mechanisms for diarrhea which has been proposed in COVID-19. First is a direct virus-mediated injury. Second one is an indirect inflammatory response-mediated damage of the GIT. Third, you use multiple antibiotics, so an antibiotic-induced dysbiosis. There is a new concept wherein the virus itself is known to induce dysbiosis in patients with COVID-19. And finally, a disturbance of gut-lung axis, wherein the respiratory flora adversely affects the digestive system by immune regulation. So these are the 5 main mechanisms of diarrhea in patients with COVID-19. Liver abnormalities have already been dealt with. Mild to moderate injury of liver is what you notice. You have mild increase in enzymes, decline in albumin, and a rise in prothrombin type. And if you do a histopathology, you will get microvesicular steatosis and mild lobular hepatitis. Now, what is of more interest, or what I would like to stress, is the relationship between COVID-19 and inflammatory bowel disease. Studies have shown that neither the presence of IBD or the use of immunosuppressors in IBD is a risk factor for disease onset. One reason for this is mentioned as these people know that they are immunosuppressed and maintain social distancing well, but it has not been well studied in any of the, in a proper study. But this is one of the reasons which most of the authors put forth as a reason why people are not more prone for disease onset.
Okay.
But once somebody develops COVID in the background of IBD, there are certain risk factors for severe disease, which is mentioned as ICU admission, ventilator, or mortality. In addition to the routine risk factors like age and comorbidity, the disease activity of IBD, and concurrent use of either steroids, thiopurines, or a combination of them with the anti-TNF have been proposed as risk factors for development of severe disease. There are some studies showing that even the administration of 5-aminosalicylates may increase the risk for severe disease. However, it is a bit controversial. What has been proven is disease activity, concurrent use of corticosteroids and thiopurines either alone or in combination. But what has been found to be protective is a monotherapy with anti-TNF, anti-integrin, anti-interleukin 12-23, or tofacitinib. Patients with IBD who are on these medications are found to have a milder disease. Regarding IBD, what has been found is that many of these patients with COVID-19 develop flare. It has been attributed mainly to stopping medicines out of fear of it interacting with IBD. So this is a congested slide which shows how to manage patients with IBD and COVID. Extreme end towards the left side, you can see patients who have IBD either in remission or mildly active and no SARS, no corona, no COVID. In this group, basically, you can continue all medications, but you should try to taper off and stop steroids, as this is found to be one of the risk factors for severe disease. In the extreme right, you have a group with severe COVID, IBD either in remission or severely mild or active. You are supposed to stop all therapies for IBD in this patient. So it is very clear cut. No COVID, you continue all medications, but try to taper off and stop steroids. Severe COVID, stop all medications for IBD. The confusion arises in the group in between. So if IBD is in remission and the patient has either just COVID positivity or a mild disease, you should try to stop steroids, thiopurines, methotrexate, and tofacitinib. So again, if the IBD is mild, you can try stopping all therapies in be it mild COVID or moderate COVID. In the next group, that is the group patient where there is a mildly active disease, you should try to stop systemic steroids and most of the therapies except budesonide, 5-acetyl salicylate, and rectal therapy. So in this group where the IBD is mildly active and the COVID is also mild to moderately active, you are supposed to give only budesonide, salicylate, or rectal therapy. In the last group where the IBD is active but the severely active and the COVID is mild, moderate, or just COVID positivity, preference is given for biological therapy. I hope I have made it clear. No corona, IBD alone, continue all therapies except steroid. Severe COVID, stop all therapies for IBD. Mild COVID, IBD in remission, stop all therapies. COVID active, IBD mildly active, you try budesonide, 5-acetyl salicylate preparation, and rectal therapies. Severely active COVID, severely active IBD, mild to moderate COVID, you can try biological monotherapy. So this is what is the recommendation as per the American Journal of Gastroenterology in October 2020. Coming to vaccination in IBD patients, all currently available vaccines, which include the mRNA vaccine or vector vaccines like the adenovirus vaccine, which is available in India, are considered to be safe in patients with IBD. There are some live vaccines which are being developed, and once they come into the picture, they will be contraindicated in patients who are on immunosuppressants. There was a concern whether there could be a vaccine-induced disease enhancement, the immunological response induced by the vaccine, whether it will increase or result in a flare of IBD. But though there is limited data, it is generally considered not to have, and vaccines are considered as safe. The major concern is not regarding the safety of the vaccine, but regarding the efficacy of vaccine. As it can be expected, the efficacy of vaccine is considered to be lower in patients with IBD on immunosuppressants. Now, if there is a question like both mRNA vaccine and an adenovirus vaccine, both are available, which one would be given to a patient with IBD. Obviously, the choice would be mRNA vaccine because it has got a higher efficacy and it prevents mild to moderate disease as well, which with a efficacy rate of 94 to 95%, while adenovirus vector vaccines are found to protect from mild to moderate disease only in around 60 to 70%. The next part, in endoscopy in the COVID era, sorry for the heading, like it is endoscopy in the COVID era, how do you do it? When there is a pandemic happening, as we all knew and was discussed extensively in many webinars, only emergency cases were performed, which include GI bleed, cholangitis or extrahepatic biliary obstruction, foreign body obstruction, perforation or leaks, stent placement, assisted feed nutrition methods, and managing of cancer complications. It has to be done after COVID testing for a patient, and whoever has been found to have a COVID positive was done in a negative pressure OT with full PPE. If the COVID-19 negative or the test was not available, still this patient could be positive. So look at the clinical picture, and if it is high risk, again with full PPE in a negative pressure room. If it is a low risk, you can either use a surgical or an N95 mask, single or double glove, face shield or goggles, hairnet, and gown and shoe cover. So this was what is recommended in the pandemic area. Now we have reached a stage where the pandemic seems to be coming down. We will know only with time, but what to do once we are restarting our endoscopy services. And that this Delphi consensus, I think you will all have to remember Delphi consensus, which was published in Gut, and it gives certain recommendations for how to restart in the post-pandemic era. So here it is recommended that all patients should be screened clinically, whether they have fever or symptoms. But absence of symptoms does not mean that this patient is not infected. For patients, it is preferable to have a test for coronavirus 24 to 72 hours before endoscopy. If it is not available, or if there are certain financial constraints, the testing is recommended at least for procedures which are expected to last more than 1 hour. So ideally, all procedures you need a testing. At least for procedures lasting more than 1 hour, you should definitely recommend a testing. What is to do? They recommend mainly point of care tests, antigen-based tests or PCR-based tests. But the antigen test which they are mentioning in this guideline is not available in India. Probably once it has a very high sensitivity rate of 94-95%. Once that becomes available, that will be actually a better test because of its rapidity with which we get the results. Healthcare professionals should also be screened and made to self-report their symptoms. All patients should wear masks when they are in the endoscopy room. Healthcare professionals should also be wearing surgical masks is what they recommend. But they in the footnote, they have given that it would be ideal to use an N95 or an FFP3 respirator. Elective endoscopy for patients with suspected or confirmed COVID should be deferred, even in the post-pandemic era. But if they have a COVID negative and they do not have symptoms, it can be safely performed. For gastroscopy and all aerosol generating procedures, even in the post-pandemic era, where patients are found to be negative, it is recommended to use N95 or FFP3 respirators. While for low aerosol generating procedures like colonoscopy, they recommend only standard PPE with a surgical mask. In the absence of testing, they recommend that every patient should be considered as positive, and you should use enhanced PPE. Donning area should be separate, and doffing area should be separate. So this is in nutshell regarding the guidelines, Delphi consensus guidelines, which has been published in Gut regarding how to restart endoscopy services in the post-COVID era. That is in nutshell a bird's eye view of COVID in IBD and regarding endoscopy services. Now in GI bleed, I found this paper which most of you would have come across. It was a very significant paper, much discussed about, which was published in NEJM April 2nd, 2020, regarding the timing of endoscopy for upper gastrointestinal bleeding. What they did in the study is that they selected 516 patients divided it equally into 250 groups of 258 each. And in one group, they did endoscopy within 6 hours of presentation. And in the second group, they did endoscopy within 6 to 24 hours. The first group was called as the urgent endoscopy group, and the second group was called as the early endoscopy group. What was interesting to note was that all-cause mortality, rebleeding, need for a salvage procedure, ICU admission were all more in the urgent endoscopy group. That thus they came to the conclusion that performing an endoscopy between 6 to 24 hours would be in fact giving you better results than urgent endoscopy. They did not include patients. One limitation which I found when I went through this article was that they did not include patients who were hemodynamically unstable, because this is the group where you need to intervene urgently. So probably if that group is also included, the results may be a bit different. But in patients who can be stabilized, I think like this message of the paper is very clear to perform endoscopy within 6 to 24 hours. Coming to esophagus, there are many papers which came in esophagus over the last 1.5 years. And one of the most important one was the Chicago 4 classification. We knew about the Chicago 3, but Chicago 4 classification was been published in 2021 Jan in Neurogastroenterology Motility Journal. The major differences, I'll skip this slide and move to the next slide. In Chicago classification, they classified disorders of esophagus into 2. Disorders of esophageal gastric junction outflow, which include type 1, 2, 3 achalasia, and esophagogastric junction outlet obstruction. They divided it in the Chicago 3, if you remember, there was minor disorders and major disorders of motility. But in Chicago 4, what they've done is they classified it into esophagogastric junction outflow obstruction and disorders of peristalsis. If the integrated relaxation pressure was found to be high, they looked at peristalsis. If peristalsis was absent and there was no increase, no panesophageal pressurization, it was type 1. More than 20% had panesophageal pressurization, that was achalasia 2. And more than 20% of swallows with premature contractions were achalasia 3. Basically, it was exactly similar to what you get in Chicago 3. But the difference was that rather than doing manometry in one position alone, it was recommended for patients with equivocal results to do wet swallows in a secondary position as well. So that was a major difference. Two major differences was one, classification divided into esophagogastric junction outflow obstruction and disorders of peristalsis. And the second one was usage of additional methods rather than just swallow in the primary position. One major investigation which has come forth in the last 1.5 years, or given more stress in the last 1.5 years, is the functional luminal imaging probe, or the FLIP. This is a novel device, FDA approved, which measures luminal cross-sectional area and pressure in the esophagus. This uses a high resolution impedance planimetry. It is not manometry, it is planimetry during a volume controlled distension. This assesses the mechanical properties of the esophageal wall and opening dynamics of the esophagogastric junction. What you have here is a machine and a probe which has 16 impedance planimetry sensors placed at 0.5 centimeter distance. And you have a very high compliance balloon which is distended and the impedance is measured. At the end of the FLIP procedure, in the FLIP one, you get an image like this, which shows the distensibility and also the pressure at various levels, which will help you to identify most of these esophageal motility. Where all is useful? It is useful in achalasia to diagnose and assess the efficacy and therapeutic modality. In GARD, to tailor the fundoplication, though there is limited data for its use as a diagnostic test. pH metry is always preferred. In eosinophilic esophagitis, to assess the fibrostenotic remodeling of the esophagus. And in strictures, to measure the cross-sectional area of pharyngoesophageal junction to guide endoscopic dilatation. So the use of FLIP is mainly in achalasia, GRD, eosinophilic esophagitis, and stricture. But there are certain limitations for this as well, which include it is costly, there is not enough expertise, and the data is still limited. But I found in all the previous question papers that there was a question regarding a recent investigation, and FLIP could be one of those. There was an excellent review in American Journal of Gastroenterology regarding management of eclasia. The major difference, most of the concepts were same, except that in the initial diagnostic approach, they include FLIP and timed barium esophageal with a barium capsule rather than a liquid barium. The treatment, I'll go to the next slide, and before that, this is a common question which comes as whenever you have a case of eclasia. So the major therapies that we have right now is POEM and laparoscopic Hellers. So the advantage for POEM is that it has got a typical shorter recovery and duration to diet in reduction. This is the major advantage for POEM, while the major advantage for laparoscopic Hellers is that it is usually coupled with a fundoplasty and has less gastroesophageal reflex post-procedure. Now, where is Hellers preferred over POEM? If the patient has a hiatus hernia, epiphrenic diverticula, or tight angulation of the distal esophagus or severe esophageal tortuosity, it is preferable to take up the patient for laparoscopic Hellers. While if it is a type 3 eclasia or spastic eclasia, it is preferable to undertake the patient for POEM. So this is what I said in a nutshell, in an algorithm. If the upper endoscopy in patient presenting with symptoms suggestive of eclasia, if the upper endoscopy is either normal or shows esophageal dilatation, resistance at the esophagogastric junction, retained food, and diverticulum, you do a manometry, barium esophagogram, or FLIP, and divide the patients into type 1 or 2 eclasia or type 3 eclasia. In type 1 or 2, you can perform all three: pneumatic dilatation, laparoscopic Hellers, or POEM. And POEM and Hellers are found to be almost equally efficacious. In type 3, though both can be performed, tailored POEM and tailored Hellers can be preferred. A tailored POEM will be the preferable choice. If the patient is unfit for a therapy, then probably you could try botulinum toxin or smooth muscle relaxants. This was another paper which came up recently from Italy, where they identified the risk of carcinoma in eclasia. They studied 566 patients for 16 years, 15.5 years, and they found that the risk of esophageal cancer was higher with an incidence rate of 104.2, which was higher in men and higher for squamous rather than adeno, 0.18% squamous and 0.06% adenoperia. So this completes eclasia. Just to complete, there is another new concept which has come up, which is a hypercontractile esophagus. This is a heterogeneous motility disorder where there is increase or a forceful contractions occurring in the distal esophagus with every swallow. This can manifest with dysphagia and chest pain. It is not equal to diffuse esophageal spasm. A cholinergic drive excess is considered to be the pathophysiological mechanism. Investigation of choice is manometry. Management, PPI can be tried, but calcium channel blockers, nitrates, and phosphodiesterase inhibitors rarely act. Endoscopic treatment with botulinum toxin or pneumatic dilatation has been tried, again with various variable utility, but the choice of therapy is again POEM for hypercontractile esophagus. Now moving over to peptic ulcer disease and H. pylori. This was a question 2 years back regarding vonoprazan. Vonoprazan is a molecule which has been studied extensively in Japan. It is a newer potassium competitive acid blocker. Now this acts not on the potassium pump, but it acts on the, it inhibits acid secretion by competitively blocking availability of potassium to hydrogen potassium ATPase. Now, the advantages of this molecule is that it is acid stable, rapidly absorbed. So it is independent of whether the patient is fasting or in the fed state. It has a longer half-life of 7.7 hours. Since it has a higher pKa, it accumulates well in the canalicular space and is a stronger inhibitor than most of the currently available PPIs. It is safe for usage in patients with kidney disease or liver disease, and it does not have a CYP2C19 polymorphism, though there is some amount of CYP2B6 and 3A45 interaction. So it can interact with clarithromycin, but not with clopidogrel. The advantage of this molecule over PPIs are the longer half-life. So you can prescribe it once a day. It is acid stable. It inhibits both the resting and activated proton pumps. It has got an immediate effect. So there is no need to precede diet by half an hour or so. And there is no clinical variability related to CYP2C19 polymorphism. Now regarding H. pylori. There has always been a question whether to treat a patient who is incidentally diagnosed with H. pylori, whether it will ultimately convert into a benefit or not. So this group decided to study patients in Matsu Islands. What they did was they did a mass eradication program launched in 2004 and continued till 2018 in the Taiwan. Matsu is in the Taiwan, so this is a Taiwanese population. And after 6 rounds of mass screening and education, they found that the treatment rate, the coverage rate reached close to 85%. And the prevalence rates of H. pylori fell from 64% to 15%. So there was an effect for the mass eradication therapy. Now they did convert to a clinical benefit as far as atrophic gastritis and intestinal metaplasia is concerned. Yes, it did. Compared to historical controls, there was a reduction in gastric cancer incidence and mortality by 53% and 25%. So this paper, the message of this paper is that any patient who is probably found to have an incidental positivity could be or should be treated for H. pylori. There are certain newer treatments which are proposed in H. pylori. The 3 major ones are PPI plus high-dose amoxicillin, wherein you give a PPI plus 750 milligram of amoxicillin 4 times a day, which makes the total cumulative dose of amoxicillin 3 grams. And this has been proposed in areas of high clarithromycin resistance with close to 88% eradication rate. Rifabutin, amoxicillin, clarithromycin is another regime. It has been proposed as a salvage therapy, but the results in studies are a bit controversial. You get around 70% clearance in patients who have failed to the prior therapy. And in a population where TB is endemic as that of ours, the implementation of this therapy may be a bit controversial. Now, what has shown promising results is vonoprazan-based triple therapy. This has been extensively studied in Japan, nowhere else, so we do not know whether the results can be extrapolated to population outside, but it shows an eradication rate of 92 to 94% using the same combination of clarithromycin and amoxicillin given for 10 days, 10 to 14 days. Now we move over to colorectal screening, cancer screening guidelines. There was this ACG clinical guidelines in colorectal cancer screening published in 2021 March, very recently, where most of the most of the guidelines or recommendations are similar to what they were in the past. In average risk individual, they recommend screening between 50 to 75 years and in between 45 and 49 years as an optional one. Beyond 75 years, they do not recommend it. It may be individualized. What test to do? Still fecal immunotesting and colonoscopy has been recommended, but they have brought in 2 new tests. One is a multi-target stool DNA test and a colon capsule. In patients with high risk, where they have a family member, first-degree relative diagnosed less than 60 years, or advanced polyp in 2 first-degree relatives, they recommend initiation of screening at 40 years or 10 years before the youngest relative who was earlier diagnosed, whichever is earlier. Now, regarding who can do a surveillance, they have assessed the quality by 3 things. One is cecal intubation rate, second is adenoma detection rate, and withdrawal times. This guideline recommends that a surveillance should have a minimum threshold of at least more than 25% adenoma detection rate. If he doesn't do that, he should be sent for retraining. The recommended screening time, as always, is mentioned as 6 minutes in this guidelines as well, and a cecal intubation rate of at least 95% should be satisfied for a person to be involved in surveillance. They recommend aspirin for patients with a cardiovascular disease of more than 10%, provided they are willing to take it, but that should never replace the colonoscopy or colorectal cancer screening using colonoscopy. So these were the major points in this guideline. But what I would like to stress is this multi-target stool DNA test. As we all know, neoplastic colonocytes exhibit increased proliferation, decreased apoptosis, and altered intracellular adhesion. So their intracellular adhesion is not very strong. Hence, they get released into the stool and can be found in a shed state in the stool. So what has been proposed is to take a stool. This is a stool test wherein the stool of the patient is, or the subject being screened is taken, and it is fed into an analyzer, which analyzes using an algorithm mainly for mutant KRAS, methylated BMP3, methylated NDRG4, and a fecal immunotest for hemoglobin. You do not know which one is, which one per se is positive, but it gives a complex algorithm at the end of which the analyzer tells whether this test is positive or not. The advantage over fecal immunotesting is that this test has a higher sensitivity. So as a screening test, this would be an ideal test. This has a lower specificity compared to FIT, but when, as you all know, when something is considered as a screening test, it should be a higher sensitivity. If you look at the sensitivity rate for colorectal cancer, the sensitivity is 92% versus 74%. For stage 1 and 2 colorectal cancers, it is 94% versus 70%. Right down till serrated lesions more than 1 centimeter, the sensitivity of multi-target stool DNA test is found to be much more higher than fecal immunotesting. So where is it applied? It is applicable for average risk screening. So it should not be given for people who are at high risk of malignancy. There, it is always preferable to do colonoscopy. So somebody with GI bleed, history of colorectal carcinoma in the past or in the family, IBD, or somebody who has a first degree relative with previous high grade polyps. So these are actually considered to be high risk individuals. In these patients, colonoscopy is still recommended. How often should you do it? Multi-target stool DNA test is preferred or is recommended every 3 years. So it is not a replacement for diagnostic or surveillance colonoscopy. It is used for screening of average risk individuals. Now, if suppose somebody is having MTS DNA positive and colonoscopy negative, no additional testing is needed, as there can be false positives. Malignant polyp is a new term which has been stressed in the present colorectal cancer screening guideline. If you have a polyp and if you have the dysplasia limited to the epithelium, they call it as tumor in situ or carcinoma in situ or intramucosal carcinoma. If it extends beyond the epithelium into the submucosa, but not into the muscularis propria, that is what you call as a malignant polyp. If something extends into the muscularis propria, then you call it as an invasive malignancy. So there should not be any confusion. As we all know, there is a Vienna classification which has been widely used. 5-2 in Vienna classification is what you call as a submucosal, malignant polyp. So malignant polyp is one which has dysplasia extending into the submucosa, but not beyond the muscularis layer. Now in bowel, actually I found this teduglutide which has been mentioned earlier on, but this was a recent review paper in it. Teduglutide is a recombinant degradation resistant long-acting glucagon-like peptide analog, GLP-2 analog. It is safe and well tolerated. The major complaints in patients with short bowel syndrome include diarrhea. So once you give it, it has found that compared to placebo, there is a double response rate in patients who are treated with teduglutide. 54% were able to reduce their diarrhea, and their improvement to parenteral nutrition, or like they could be weaned off from parenteral nutrition to enteral feeding. I couldn't find much papers in pancreas which are of importance in the last 1.5 years. Most of the papers which have come in pancreas are mainly related to ERCP, which has Matthew Phillips sir has already discussed or already stressed on. So one interesting paper which I could find is in a group of patients with severe acute, prevention of severe acute pancreatitis in a patient who is having a high risk for development to that. So at the time of admission, using the Glasgow score, they identified patients who are at a high risk of developing a severe pancreatitis. In addition to standard therapy, they supplemented a COX-2 inhibitor to this group, which could either be a parecoxib or a celecoxib. And they were administered, and the severity was, they were followed up to assess whether they developed severe acute pancreatitis or not. It was found that in the group who was co-administered COX-2 inhibitor, the incidence of a severe acute pancreatitis was 47% lesser compared to the group who were not given it. So sequential administration of a COX-2 inhibitor in patients with predicted severe acute pancreatitis obtained half reduction of severe acute pancreatitis occurrence by decreasing levels of TNF alpha and interleukin 6. So this is something which can be useful in our day-to-day practice, probably addition of a COX-2 inhibitor to patients who are at risk of developing severe acute pancreatitis. IBS, again, there are not much recent developments except two drugs, ulexodolin, which is actually a combination of a mu and kappa receptor, opioid receptor agonist, and a delta receptor antagonist. Now it is effective in patients with IBS diarrhea. It reduces global symptoms in the form of pain and bowel symptoms. And it is effective in individuals failing to respond to over-the-counter loperamide. So IBS diarrhea, it has been a nuisance. There have been previous therapies like rifaximin, probiotic, and presently there is another molecule which is FDA approved, that is eluxadolin. In IBS constipation type, there is a new molecule which has been approved in 2019, and that is actually tenapanor. Tenapanor is a potent inhibitor of sodium hydrogen exchanger 3, which is located in the apical membrane. No, so what this does is it prevents the uptake of sodium ions. So it increases secretion into intestinal lumen and results in improvement of constipation. 50 milligram twice a day is a dose, and the on-systemic action of tenapanor constitutes a significant advantage with minimum adverse effects. The adverse effects are very minimal, like diarrhea, abdominal distension, flatulence, and dizziness. For a patient with IBS constipation, it can cause a problem and there is flatulence and dizziness, but majority of the patients have an increased improvement in their symptoms. Now to the stress part of my session, majority of the developments has been happening in IBD. So I think like in the rest of gastroenterology, maximum papers were in either COVID or in IBD. So this will be another part which I will be dealing with. Treatment or newer molecules or newer treatment modalities for IBD can be classified into two: biologics, which include anti-TNF, anti-alpha, or small molecules, which are newer molecules like JAK inhibitors, S1PR inhibitors. So the difference between biologics and small molecules is that biologicals are proteins, while small molecules are chemicals. Most of the biological requires either an IV or a subcutaneous administration, while small molecules can be given orally. Biologics have a variable 3D structure because like there are biosimilars which can be used. So it may not be the exact structure for every molecule, while in a small molecule, they have a well-defined structure. Biologics, being proteins, are catabolized, while metabolism in the liver or in the kidney happens with most of the small molecules. Mechanism of action in biologics are they are antibodies, so they block or they deplete, while small molecules are chemicals which inhibit the enzyme. The biggest difference between the two is the cost. Biologicals are highly costly, while the small molecules have low or intermediate cost. If you look at the biologics, they can be various groups. The first group, or the most important group, which we are all commonly using nowadays, is the anti-TNFs, which include infliximab, adalimumab, certolizumab, and golimumab. I think like this is no longer new because most of us are experienced and are using it, and hence I will not be discussing anything further regarding this. The newer molecules are the integrins, of which the most important ones are vedolizumab and natalizumab, but natalizumab is not gut specific. It can cause severe reactions and progressive multifocal leukoencephalopathy in patients who are administered that, and hence majority of the trials and the stress is on vedolizumab, so I'll be discussing about it. Anti-MADCAMs are newer molecules which are coming up, but their data is limited. In the integrin alpha 4 beta 7, vedolizumab acts on the receptor per se, while natalizumab acts only on alpha 4, and etrolizumab acts on beta 7. It's a bit difficult to remember all the names, but I think like you need to get the concept clear, that's all. In IL-12/23 antagonists, you have ustekinumab and brazikumab, but majority of the papers are again on ustekinumab. So first, starting with vedolizumab. Vedolizumab, when you have a monoclonal antibody, it is easier to know like what molecule is it by looking at the name per se. If you have iximab, it is a chimeric molecule. If it is an umab, it is a human molecule. And if it is a zumab, it is a humanized molecule, antibody. So vedolizumab is actually a humanized IgG1 monoclonal antibody against alpha 4 beta 7 integrin. As I mentioned earlier, compared to natalizumab, which is another anti-integrin, this is gut specific and has action limited to the gut. Now it is given as an IV infusion in a fixed dose. So it is easier to remember the dose as well. It is given in a standard dose of 300 mg. Where all does it play a role? It is approved for the induction and maintenance in both ulcerative colitis and Crohn's disease. It is especially recommended as a first-line biologic in ulcerative colitis, especially in the elderly at increased risk of infections and malignancies. As I mentioned earlier, this is gut specific. So the side effects are very low, and the malignancies, which is a dreaded side effect of many of the biologicals, is very low in such patients. And hence it is safer for patients with mild or moderate active disease. Though it has been, I will come to that later on. It has an excellent safety profile due to its gut specificity and minimal adverse effect in the form of nasopharyngitis and sinusitis, and lesser incidence of PML. And in our setup, it has got lesser TB flyers compared to most other molecules. So safest among the molecules right now would be vedolizumab, but it has got a disadvantage. Though it has been recommended for induction and maintenance of patients who are having both ulcerative colitis and Crohn's disease, its onset of action is very slow. So in patients who are very sick, requiring aggressive intensive therapy from the very beginning, this may not be an ideal choice, except in the context of bridging a co-induction therapy with either steroids or cyclosporine. So the take-home message in vedolizumab is it is an anti-integrin. It is a humanized IgG1 antibody given as IV infusion in a fixed dose. It is an excellent molecule for induction and maintenance in UC and CD because of its safety profile, but it has a slow onset of action and may not be the ideal molecule for patients with severe disease. You just need to remember the trials. In Crohn's, you have the Gemini 2 trial, and in ulcerative colitis, you have the Gemini 1 trial for vedolizumab. They have shown good response, but as you could see, the initial response, the response is found to build as it reaches week 6 in patients rather than the initial phase, probably because of its slow onset of action. Next, coming to ustekinumab, which is an anti-IL-12/23. This is again approved for treatment of both Crohn's disease and recently for ulcerative colitis as well. This is given through both routes. First, you give a IV, weight-based IV infusion, then follow it up with fixed 90 milligram subcutaneous injections every 8 weeks. The benefit is mainly due to interleukin-23 response rather than the interleukin-12 blockade. Now, the trials for this are mainly the Unity trial, Unity 1 and 2 in Crohn's disease, and the Unified trial for ulcerative colitis. You see that it has got an excellent response. The first trial, that is Unity 1 trial, was when ustekinumab was given for patients with anti-TNF failure. So these were patients who had earlier given a biological, they failed to it. As a salvage therapy, you gave ustekinumab. And you find that the response was much higher in the Unity trial, which included patients who were biologic naive. So the earlier you start using it, the better the results is what is given in most of the, evident in most of the studies. This is a recent trial published in 2019 NEJM. This is called as a Unified trial. This is for ustekinumab in ulcerative colitis. Here, what you did was, the authors compared with placebo 2 groups of ustekinumab. One was a fixed dose regime and the other was a weight-based regime of ustekinumab, 6 mg per kg or 130 mg. You find that the difference is not, difference in remission at 8 weeks is not much different. Now, this was followed up by ustekinumab 8 weekly subcutaneous doses or 12 weekly doses, and it was found that every 8 weeks dosing had a better response of 43.8% compared to 12 weekly dosing. So hence it is recommended right now to give an initial IV bolus followed by a subcutaneous 8 weekly injections, which is evident from the Unified trial. So remember the trials again: Gemini 1 and 2 for vedolizumab, and Unity and Unify for ustekinumab. There has always been a question regarding the efficacy or the safety of biologicals in pregnancy. And this was a very recent paper from clinical gastroenterology and hepatology. I'm not going into the details of it, wherein it was found that IBD women on biologics had same safety as far as pregnancy is concerned compared to general population. So it was not the popular notion that you have to avoid biologicals in pregnancy may not be true, but it requires further studies regarding the same. Now, one of the common problems that we face in Indian population, and hence I have brought forth this study, is many of our patients have to stop anti-TNF once they have started it. So what happens to this group of patients? It helps in prognostication, it helps in telling patients like what will happen when you are stopping anti-TNF. This was a paper from Professor Vinita Ahuja's groups from AIIMS, Delhi, published in Indian Journal of Gastroenterology. And there they have, 45, they have included 57% or 45 patients where anti-TNF was withdrawn, either because of a financial burden or TB reactivation, while of which 33 were in remission at the time of withdrawal. Over a median follow-up, it was found that close to 15 patients, that is 45.5%, relapsed. So most of them responded to antibiotic, steroids, or anti-TNF again, or 3 required surgery, but telling that when you are withdrawing anti-TNF after a period of 6 months or 1 year, you always explain to them a risk of developing a flare within in around 50% of the cases. Now, there is an important concept of biosimilars. What exactly is a biosimilar? Now, when a anti-TNF or a biological is first found out by the manufacturers, it is called as an innovator molecule. Now, it is most often patented. So other companies or other manufacturers cannot manufacture it. So they go in and identify a different route through which a very similar or a similar molecule can be made, so that the basic amino acid structure remains the same, but the side molecules or the glycosylation chains may be different. So it is almost like whiskey and rum. You have the same effect, similar molecule, but they are different. So biological agents that are highly similar to an existing FDA-approved reference biological, notwithstanding minor differences in clinically inactive components, but no clinically meaningful differences in terms of safety, purity, and efficacy, is called as biosimilar. So the difference arises mainly from their manufacturing method. The backbone is the same. So the amino acid sequence is the same. the dress is different. So there may be subtle difference in glycosylation. Their efficacy, safety, purity are all the same. But they differ in their pharmacokinetics and in their immunogenicity. So some may be developing an immune response earlier, some may behave differently. So then came the question, the advantage for biosimilar was that they were much more cheaper. So then came a question whether somebody uses an innovative molecule can be switched on to a biosimilar. There came a very important study, which is called as a NOR switch trial, which showed that when people on an innovative molecule were switched to a much cheaper biosimilar, the efficacy remained the same, thereby showing an advantage for biosimilars. When I started IBD, I told I will be dealing with a second major group, that is small molecules for treatment of IBD. This include three group of molecules. They are the Janus kinase inhibitors, sphingosine 1-phosphate receptor inhibitor, and phosphodiesterase inhibitor. So this could be a question this time round, small molecules in IBD or Janus kinase inhibitors per se. If you look at the three mechanisms, this is how each one of it act. JAK kinase is actually a pre-runner to STAT, which helps in the activation of transcription in the nucleus. This results in the production of many interleukins. So if you block the JAK by either tofacitinib, filgotinib, or peficitinib, it will block this pathway, result in a reduction in the production of interleukins, thereby resulting in a decrease in inflammation. And that is the mechanism of action of JAK inhibitors. Phosphodiesterase and PDE4 enzyme actually helps in the conversion of CAMP into AMP, which activates the protein kinase, which results in activation of NFK beta and CREB, which results in increased production of inflammatory cytokines. So apremilast, which is a PDE4 inhibitor, prevents this from happening. Sphingosine 1-phosphate receptor is actually, sphingosine 1-phosphate is actually a component of the cell wall. Now, this is important, or S1PR is important in the transfer of lymphocytes from the lymph node to outside. Okay, so these lymph nodes are the ones which cause inflammation. So if you modulate the S1PR and prevent the lymphocytes from coming out of the lymph node, you can prevent inflammation. So that is how S1PR receptors, receptor 1 modulators act, which are the ozanimod and etrasimod. Where is all these small molecules indicated? They are indicated in corticosteroid failure, failure of biologics, in combination with the previous therapy, for extraintestinal manifestation. They have a finite duration of therapy, and what is found is that when you start the molecule again, they have a similar response. So that is what is called as a stop-start therapy. Whenever you want a limited period of therapy, when the patient is having a flare, you give it, stop it, just like steroids. So in such a group, it is effective. And it is also found to have an additional benefit of inhibition of liver fibrosis, which is known to happen in patients with IBD. So JAK inhibitors in IBD could be an excellent topic, as Varghese was suggesting. They exert their anti-inflammatory action by blocking the binding of ATP to Janus kinase, thereby preventing the subsequent activation of STATs. Now, once this happens, the transcription comes down, the interleukin production comes down, and there is a lower risk of immunogenicity as well. The major molecules here is tofacitinib and peficitinib. I will not be going into the details of this. Remember the OCTAVE trial for tofacitinib and for filgotinib I will come to later. So tofacitinib is a new molecule which acts on JAK1, JAK2, and JAK3. It is useful for induction and maintenance of patients with ulcerative colitis. The efficacy of tofacitinib for patients with Crohn's disease has been studied, but it has been disappointing, and it is no longer recommended for Crohn's disease. So tofacitinib is mainly for Crohn's disease. You give it in 10 mg BD or 5 mg twice a day doses. The major side effect is herpes zoster. So herpes zoster and opportunistic infection is a major side effect, One other major side effect which has been found in some of the studies is the development of clots in the blood, especially pulmonary embolism. So herpes zoster and pulmonary embolism is the major dreaded side effects of tofacitinib. So regarding tofacitinib, it is a JAK1, 2, 3 inhibitor. The trial is Octave trial. It is found to be effective for induction and maintenance in ulcerative colitis, not effective in Crohn's disease. The side effects include herpes zoster and pulmonary embolism. Regarding osanimode, I will not discuss anything further because these are just trials which are on phase 2 trials. So I will not be burdening you with more names. Like, you just remember the mechanism of action, that is sphingosine 1-phosphate receptor modulator. And the trial is touchstone for osanimode and etrasimode. It is Oasis study. Apremilast and cartogrest is actually again new molecules, but I think you just remember the names in case an exam a question comes in the exam. Now, regarding JAK1 inhibitor in Crohn's, it has been found that this molecule, that is filgotinib, works well in the study called as Fitzroy study. So this is the only JAK1 inhibitor. If this question is like JAK1 inhibitors in IBD, probably filgotinib is what you have to remember. But one of the major complications with filgotinib, in addition to infection, was testicular cancer. So that is something which you need to be worried about. Upadacitinib is another JAK1 inhibitor in a UHU study, which was found to have a good endoscopic and histological remission in Crohn's disease. So basically, JAK inhibitors, remember about tofacitinib, filgotinib, and upadacitinib. Filgotinib for Crohn's and tofacitinib for ulcerative colitis. There are certain other molecules, again, just for the sake of knowing the names. Mongersen is an oral antisense oligonucleotide that specifically binds to SMAD7 messenger RNA and prevents its transcription by inhibiting. Then there is abrunulumab and etrolizumab, which is a beta-7 antagonist, as I mentioned earlier. I think that with that, I complete an overview of IBD. Then there are two, I'll stop in 5 minutes. I know it's 9 o'clock. I will stop in 5 minutes time. There are two recent concepts which have come in right now, which are the paraprobiotics and the postbiotic. We all know about probiotic, which are useful bacteria. Then came prebiotics, which are giving substrates to feed for the bacteria. So you give digestible fibers or carbohydrates or something which helps the bacteria to preferentially grow. Then came a synbiotic, which is a combination of a prebiotic and a probiotic. And now there are paraprobiotics and postbiotics. Paraprobiotic are actually inactivated organisms. You kill a lactobacillus by either, or you inactivate a lactobacillus by either heat radiation or ultrasound or ultraviolet radiation, and give it, and still it is found to have an beneficial effect with no side effects which are likely to be because of the bacteria per se. So paraprobiotics, also known as non-viable probiotics, refer to inactivated bacteria. Postbiotics, on the other hand, refer to soluble factors, which can be products or metabolic byproducts secreted by the viable bacteria or released after their death or lysis. So postbiotics contain many molecules like surface proteins, cell-free supernatants, cell lysates, bacteriocins, enzymes, glutathione peroxidase, superoxide dismutase. So these are all products of bacteria which are isolated from the bacteria either while they are alive or when they after their lysis, and that is given. That is what you call as postbiotic. The advantage is that you can have a specific benefit by supplementing just the bacterial byproduct alone. Some other things that you need to know when you are preparing for your exams include machine learning or deep learning, which is actually usage of artificial intelligence in endoscopy, which Matthew sir has already known. The basic concept is each image is converted to a language of numbers, which is fed to a computer, which utilizes an algorithm to give an interpretation. When you use multiple artificial neural layers of artificial neural networks, it is called as deep learning, which is a higher level of artificial intelligence. Then comes liquid biopsy, which is another fancy name. This is actually a blood of a patient with a malignancy is taken. You study for the various, tumor cells and the changes which are happening in it, and diagnose whether this patient. So instead of taking a biopsy, you study the tumor cells which are circulating in the blood, and that is what is called as a liquid biopsy. Anti-Siglec 8 antibody is used for eosinophilic enteritis. This is not a part of my topic, but I thought like this was a focus point of discussion in the last AASLD meeting, and hence could be of importance in patients with unresectable HCC. These are patients who are otherwise candidates for sorafenib or other newer molecules like nivolumab or lenvatinib. And in this group, a combination of etazolizumab and bevacizumab works well, with a 2.5-month increase in disease progression and a response rate of close to 1/3%. That is 27.3%. This is called as a IM Brave 150 trial. Semaglutide is a GLP-1 receptor antagonist, which is recently published in NEJM February 2021. You give it and it results in excellent weight loss with minimal side effects. I mentioned it here because of its possible benefits in NASH. Cobitolimod is again a rectal therapy, which is an anti-TLR9, and it is useful as an enema in left-sided UC in the CONDUCT trial. But I want you all to read these articles. There was a wonderful review regarding tuberculosis and IBD, what all to test, what are the various guidelines regarding starting biologicals, what vaccinations to give, by Ruba Banerjee ma'am in Gut Liver 2020, November 15. There was a comprehensive review in vaccination in patients with IBD. This is not regarding COVID, other vaccinations, which could be a question when you get a case of IBD. A de-escalation of immunomodulator and biological therapy in inflammatory disease. How do you de-escalate it? There was a wonderful review in Lancet, volume 5, January 2020, and practical guidelines in endoscopic treatment of Crohn's disease strictures, a consensus statement by the Global Interventional Inflammatory IBD group. I think with that I conclude. Thank you all for your patient listening. I look forward to the comments of my teachers and various other parts. Thank you.
Thank you very much, Sojan, for excellent disposition. You've touched almost every topic, and it is like a what do you say? It is like a school teaching session, like a crash course. I'm sure it is very useful for all the residents. Now I invite all the senior faculty, Vinay Kumar sir, Dr. Ismail, Dr. Bhanu, Dr. Nandakumar. I can see so many names in the participant list. Dr. Saju. So I'm sorry if I missed anybody. Please give your comments for the exam.
Can I make a comment then?
Yes, sir.
Okay. Yeah, I think, good Sojan. Thank you very much. That is exactly what is expected of you. I think, the importance of your talk is not just the flashy presentation. What is usefulness is that it will be very useful for the exam going PGs. It may not be very useful for the practitioners, but it will be very useful. But I think this is the practice which we used to do many times, for many years, when we used to prepare for the exam. So you will be taking all the journals, important journals, and then, painstakingly going through each and every article and which could be relevant, and then we'll be discussing. So it's not possible for all these exam-going students to prepare everything. So I think we used to divide among the PGs, so various topics, various aspects, so liver, the endoscopy, gastroenterology, etc. So that, combining, pooling everything, you will get a comprehensive idea. So I think your presentation, I'm very sure that, is very important in the fact that there won't be any omission there. That means that, if the the students actually go through this presentation, well, you need not actually bother about, about the journals. That is the importance of your presentation. I think there is no omission there. It's very easy to pick up a few articles and highlight them, but there will be a lot of omissions. You need to again go through all these journals. But your presentation, as you have actually given the introduction itself, that you have painstakingly compiled all the articles after going through all the journals, and then being presented. So I think there's no omission. So that is the highlight of your presentation. So I'm very sure it will be very, very useful to all the PG exam going students. And I feel that this is the way the article, the reviews have to be done in each of the topics. So I think congratulations to you. You have done your job, excellently well. I'm proud of you.
So, Soja, that is a glowing tribute from your favorite teacher. So, I'm sure you're feeling at the top of the world. So, we all feel the same. So, other senior faculty are there. Please give your comments. Dr. Ismail. Sir,
Dr. Rajesh is there.
Yes, sir. Dr. Rajesh is there. Yes, I'm sorry. Dr. Rajesh, please give your comments.
Any faculty want to add on anything which you think is relevant for the examination point of view? Any recent advances? You may please please tell us.
I think with this we complete the recent advances session. So we'll be looking forward to other faculty to chip in with some other articles which are very essential for postgraduates. They are all preparing for the...
Yeah, everyone is preparing. And of course,
we have students also here, people who are actively reading. If you want to put in any point which you want to make,
that's a very important point, Dr. Sijia. Even students can chip in because they must be most up to date than us. Okay, if anyone wants to chip in with some additional information, they can as well. But this has been a real feast, academic feast. I am sure, Sojan, your mentor was extremely proud of you. There are some situations when a teacher feels very proud of the student. This is one of the occasions. I am sure Professor Vinaykumar must have been extremely happy, and the words which he said really comes straight from the heart.
Thank you, sir. Like, I mean, like, it is basically a style which I followed. So I'm sure that sir would have, like, this was the level of sessions that we used to have. I'm sorry to disappoint the faculty in the group, but since this was aimed mainly as an exam orientation, I thought like this would be the best way forward. Thank you, sir, for like, I mean, the one who taught me to do this.
No, this is what I expected, and you have exceeded my expectation. So this is a wonderful presentation. So there is no need to be sorry. It was a great. Professor Vinaykumar is again wants to add on.
No. I'm just participating in the felicitation of Sojan. It's my pleasure. So I just wanted to be there. That's all.
Okay, this is I think that the DNP examination is almost I think from next day onwards, I think, and best wishes to all candidates for your examination, and hope all of you will pass in flying colors. And next session is actually before I want to talk about next session, I want Dr. CJ to formally conclude. Dr. CJ, you are not visible to us. Can you switch on your video?
Yes. So, Sojan has made a wonderful presentation and covered all the topics of gastroenterology, recent advances, and I'm sure like Vinaykumar sir said, it is the most useful session for all the residents, and they can just follow and I want to ask Sojan, if you have recorded it, it can be provided to the students.
So we are recording every session. We will make arrangements like some people are dealing with it. I think we will send it in the group whom to contact to get the slide. Recording.
Okay.
It will be.
And it's PPTs, slides also maybe can be shared if you are not.
Yes, I will share it in the group, sir. I'll share it.
That will be great.
Yes, if we can have the link posted in the group, it will be very useful.
So do we have permission of Venkatakrishnan sir to share his slides, or
we'll have to take permission?
Yes. We'll take permission and then share it as soon as possible, because if you give it to the Sun people, they'll take their own time. They'll make it into a CD and then we have to go behind it. So after each class, if it is possible to give the link So it will be nice if students have been writing it down. They can make notes as soon as possible.
Yes, sir. We try
So
to do
they
it.
can follow it
Dr.
up.
Sojan, if you have no objection, you can share your slides immediately after your
No,
talk.
sir. I'm doing that. I'm doing that.
Okay, great.
And
Great.
Sojan?
Hi, sir. Nandoma, sir.
Sojan, so
Yes,
it's
sir.
very great. You have taken exhaustive effort actually.
Thank you,
Very
sir.
nice. And one thing is, if we can actually put the studies exactly, which article, which okay, if you can do that also, that'd be more nice actually.
Yes, sir. I will try to put all the articles into the group as well.
Yeah, if you can get the original articles,
yes,
especially since you have put in so much of pain. So
yes, sir. I'll do that,
we
sir.
can,
Like most of the articles are with me, I will put it into the group.
yeah, that way then it's much more easier to go into the depth of some doubts of regarding the studies and others.
Right, sir. Sure. Sir.
Very, very well done, Sojan. Well done.
Thank you, sir. Thank you, sir.
Okay, Srijaya, now.
Yes, sir. Thank you very much. Thank you, Sojan, and thank you, sir. Thank you, everybody.
Okay, so thank you, Dr. Sojan, for your wonderful talk. And remember, Sojan is part of the team. It's the coordinating team. Today, I have given him extra job. So apart from doing all the coordination, he has additional job. I wanted young blood to be a part of the teaching program because
I should say that I should thank you especially because like when you said to me, I thought like it would be a headache, but I think like I am the one who benefited most. Thank you so much.
Definitely, it is always the presenter who benefits most. But how long did you take to make this, Sojan? 3 days?
no.
This time like Varghese sir himself took the responsibility of coordinating the meeting. I stayed away from it. That was it.
For making presentation.
Maybe like 3 weeks. I mean, he told me like 3 weeks back. So since then I started preparing.
Okay, that is extensive and very useful for the students.
So thank you, Dr. Srijaya. Thank you, Dr. Sojan. And our next session will be by Professor Narendranathan. And then Professor Narendranathan, you all know, is the best expert on research methodology. And unlike when I requested him to do research methodology, Professor Narendran said that he will do research methodology in a new style. He will give you the article, ask you to read, and he will present the article and criticize the article and its methodology. That's the best method to learn. Okay, so next week we have Professor Narendranathan, and the article also will be circulated to you. So please read over the weekend. You please read and prepare, and all of you, both faculty as well as the students, and be ready. Professor Narendranathan will be asking questions definitely. Okay, and after that we have we restart the clinics, and from 30th onwards till the end of examination we will have clinics almost every week. We may even have twice weekly clinics. We are already planning an instrument session, pathology session, radiology session, etc. So in the next 2 months everything will be there, and it will be a sort of hectic activity, and I request the help of all the students as well as all the faculty for the success of the program. With these words, we formally conclude, and good night to all of you, and have a nice evening. Thank you.
Thank you, sir. Good night. Good night, ma'am.
Special
Good
thanks to
night.
Dr. Srijaya.
Thank you very much, sir. Thank you.
Okay, we will leave soon.